Alright guys, let's get busy talking about our placenta and our umbilical cord. We're going to start off by talking about our placenta and all of its amazing functions. Then we're going to move on to talking about our umbilical cord and some of its derivatives. And we're going to wrap up by talking about our umbilical pathologies. So let's go ahead and get started by talking about our placenta. And in terms of the anatomy, we're going to be looking at three parts. Let's first start by talking about the decidua bassalis, which is going to be the maternal component, and the chorionic plate, which is going to be the fetal component. So if we look at our diagram here, we're going to have our decidua bassalis right along this portion of the placenta, and this is going to match up with here the uterine wall, whereas the chorionic plate is going to be this portion that I'm highlighting here, and this is the part that's going to interface with the umbilical cord. And then in the middle we have something called the intervillous space, and this is going to be a mix of maternal and fetal components, and we're going to have a lot of gas exchange going on here and nutrient exchange, and it's kind of like the middle ground here between the fetus and the mother. And so if we look at the hormone production that's occurring in the placenta, it's really important. So we have beta HCG, which is going to be from syncytiotrophoblastic cells, and this is what's going to keep the pregnancy alive during the first 10 weeks by ensuring that the corpus luteum continues to make progesterone. We also use this as a marker for positive pregnancy tests. We also have human placental lactogen, which is going to be a derivative of human growth hormone, and this is going to lead to growth of the fetus, and it's also going to contribute to insulin resistance in the mother. And then finally we have progesterone, which is going to be produced by the placenta like starting around week 10. Prior to that, the progesterone is coming from the corpus luteum in the mother, but in week 10 the placenta is going to take over and make all the progesterone necessary for pregnancy. The placenta is also going to be the site of fetal gas exchange, so we're going to get exchange of oxygenated and deoxygenated blood, which we're going to move on to talk about now that we talk about the umbilical cord. So talking about the umbilical cord, let's kind of take a look at where it is in our diagram. So it's going to be like this black area that I have highlighted here, and the umbilical cord is going to contain a number of important structures, and let's kind of go over what those structures are responsible for. So if we take a look here, this black dot represents our umbilical cord, which is a derivative of the allantois, and our allantois is going to have multiple derivatives coming from it, and they're going to manage things like urine, deoxygenated blood, oxygenated blood, as well as feces. And then if we take a look here, let's kind of go over these pieces. So we have the allantois, which we said was this black structure that is kind of responsible for a bunch of other derivatives. And so let's start out by talking about the allantois, which is going to turn into the urachus. And if we look at the urachus, it's going to be this yellow area here that is responsible for all the urine management and like basically the primitive bladder of our embryo. And eventually the urachus, after the bladder has fully formed, is going to go ahead and regress into the median umbilical ligament, because we no longer need a connection to mom if the fetus has a well-working bladder and external genitalia. So let's move on now to talk about our two arteries, which are going to carry deoxygenated blood. And this is really strange, right? We usually think of arteries as carrying oxygenated blood, but in the fetus, our circulation is a bit reversed. We're going to talk about this more in our next video on fetal circulation, but I wanted to talk about derivatives of these things today. So we're going to talk about the fact we have two arteries. And if we look here, we can see these two arteries in a cross-section of our umbilical cord. And I cannot stress enough how high yield this cross-section picture is. The test writers love to ask about this on test day. And these two umbilical arteries are going to go ahead and they're going to come in and they're going to branch off to become essentially the internal iliacs in the future fetus, and at which point the circulation will be reversed and those will be like arterial supply carrying oxygenated blood. So interestingly, we can point out these umbilical arteries due to the fact that there are two of them, and also that arteries are going to have a much thicker walls, right? They are very musculature type vessels, and so it's easy to differentiate these from the umbilical vein, which is a compressible structure. It's much more flat. It's not holding its structure as well as these two arteries. And it's also easy to note that there's only going to be one vein and there's always going to be two arteries. So let's go ahead and talk about our vein now, which is going to carry oxygenated blood from mom. And basically this is going to go up to what will become the future inferior vena cava. And we know that inferior vena cava is a venous structure normally carrying deoxygenated blood, but in the case of the fetus, it's carrying oxygenated blood. So everything here here is kind of in reverse. And if we were to highlight our umbilical veins, it would be this structure here. There's only one umbilical vein as opposed to the two umbilical arteries. And that's an important thing to know when looking at this cross section. And then if we look at our allantois here, it's going to be this little yellow dot here. And this is where the urine is going to come from the urachus. And then finally, let's talk about our vitelline duct. And so our vitelline duct is going to connect our yolk sac to our midgut lumen. This is a structure that is going to regress around week 7. So we don't actually see this in our umbilical cord because it's far too early. The yolk sac is going to be like a very early structure in pregnancy, so it's going to regress. However, if this regression is impaired, we can have some pathology. But I just wanted to orient you guys to the various names of all the things that come from the allantois before we move into pathology. So moving into our disorders, let's go ahead and start by talking about the disorders of our vitelline duct. So these are going to be vitelline fistula, vitelline cyst, as well as Meckel's diverticulum. So if we kind of zoom in here, we're going to see here what we have would be described as normal. So this is our GI tract that has developed. This was long after regression of the vitelline duct in week 7. And you'll see that this here would represent our umbilicus, and this pink portion is our abdominal wall. This is what a normal fetus would look like. If we have pathology here, we can have a vitelline fistula where this connection does not properly dissolve, and we basically have a connection with our GI tract to the outside, right along the umbilicus where the umbilical cord used to be. And essentially these patients will be born and they will have meconium, or fancy word for poop, coming out of their umbilical cord. And so this can be repaired surgically. It's not a huge deal, but it's something that you have to be able to recognize on test day when you see meconium coming out of a fetus's umbilical cord, and it's important to understand the embryology of why this happens. We can also have something called a Meckel's diverticulum, and the test writers are obsessed with Meckel's diverticulum. Like, I'm still perplexed by how obsessed they are, so really pay attention to this because they love it. And essentially the diverticulum here is going to be like a quasi connection. So it's not like a full patent connection like the fistula, but it's like an outpouching that didn't completely resolve. And they like to ask a lot of questions about them because they are really common in like everyday life. 2% of pregnancies are going to have this in them. So if we look at the details, it's going to be a protectinate uptake study that is going to diagnose this. So it's essentially like an uptake dye that is going to like fill up the area of the diverticulum, and it's going to show it. And then it's also going to be referred to as a true diverticulum, and this is important because it has all the parts of the normal GI tract, so it has all the layers, and so it's a true diverticulum as opposed to a false diverticulum, which may only have like one layer of epithelium that is like coming out as opposed to all 2 or all 3. And then it's going to be 2 times as likely in our male patients. They're going to be about 2 inches long, and they're going to be 2 feet from the ileocecal valve, and they're going to occur in 2% of the population, which I mentioned before. They're going to be like the most common anomaly here in the GI tract. And then there are going to be 2 types of epithelium usually, which are going to be gastric and pancreatic most often when it comes to answer choices. So I want to give you guys this rule of 2s, I like to call it, because it's a true diverticulum, which rhymes with 2, and then we have 2, 2, 2, 2, 2 all the way down. So you have to know all these things about Meckel's diverticulum because they will ask about it on test day. It's incredibly high yield. And then in terms of symptoms, we can expect melena and hematochezia because essentially there's like probably poor blood flow here. We can get like necrosis and irritation in this area. That's going to show up as blood in our stool. And then they're also going to cause abdominal pain. And this is important because patients with a Meckel's diverticulum will have no outward symptoms here on the outside, like poop coming out of their umbilicus. It's just going to appear normal on the outside, so we have to rely on these symptoms in order to diagnose it. Moving on now, let's just briefly mention vitelline cyst, and this is going to be basically partial obliteration of the vitelline duct. So we're going to have like a small cyst right around our umbilicus, and this could be corrected surgically. They don't ask a lot of questions about this one, but I just want you to know like the difference in the progression of these pathologies. Now let's talk about our single umbilical artery, which is going to be highlighted in blue because arterial structures in this case are going to be blue in our babies because they are carrying deoxygenated blood, and this is going to be associated with chromosomal abnormalities. So if you were to look here at our cross section, if you only saw one of these umbilical arteries, that would be in connection with a third order question. That's going to be like, what is this child at risk for? And you have to be like, chromosomal abnormalities. Got the point, moving on. So I just wanted to give you guys that. And then finally, let's talk about our urachal pathology. So we can have a completely patent urachus, and this is going to be very similar to our vitelline fistula, which we talked about before. And if we look at the analogous thing happening in the urachus here, we'll see that we have a connection with the bladder that is coming out of the umbilicus. So you can expect these babies when they're born to be peeing out of their belly button, which is really wild. It's crazy to think about. But if you think about the embryology, I asked you guys to hold on to a fact previously about the fact that the urachus becomes the median umbilical ligament. And if we look here, this is the median umbilical ligament. So there is like a connection that's a ligament that connects our umbilicus to our bladder, and sometimes this stays open, and this is a patent urachus. We can also have a urachal cyst, which is just like basically a lake of urine in the middle of that ligament, or we can have a urachal diverticulum, which is like the bladder kind of outpouching upwards towards the umbilicus, but it doesn't really get that far. So in terms of recognizing this on test day, you need to know like how patent this hole is going to be, and you need to be able to identify which of these three pathologies it's going to be. And like I mentioned, we're going to have a partial obliteration, which we're going to call a urachal sinus. So in terms of our high yield review, I would say it's important to know the hormones that our placenta is going to make, and that its role is to facilitate all types of exchange in the mother and the fetus. And then it's really important to know your allantois and all of its derivatives. So being able to understand that each of these derivatives is responsible for a different substance, and then being able to identify those here in our cross section is going to be super, super high yield. I also didn't mention, but they sometimes ask about this substance called Wharton's jelly, and it's just the jelly that is surrounding all these structures in the umbilical cord. Then I would make sure that you know your pathologies and which structures they come from, and then depending on how patent these tubes or these imaginary tubes that are supposed to regress, depending on how patent they are, is going to determine the name of the pathology. And the one that I would really commit to memorization is going to be Meckel's diverticulum. Test writers are obsessed with this, and you need to know it for exam day. I promise you it will show up. So I hope you guys enjoyed this video. I can't wait to see you guys in the next one.